Greetings from the Department of Oral Medicine and Radiology. I am Dr. Yeshoda, and today we will be talking about the basic principles of CBCT, or cone beam computed tomography, a very important imaging methodology used in the field of oral radiology for the diagnosis of multiple disorders, ranging from your minute dental caries to the maximum of traumas and tumors, cancers, so on, so forth, and so forth. So today we cover the basic principles of CBCT imaging. We will be covering it under the following topics of introduction, history, the principles of the imaging, as well as the conclusion and the references for the same. Introduction. Cone beam X-ray CT is a relatively recent installment in the growing inventory of clinical computed tomography technologies. It was developed for angiography in 1982, but eventually introduced to maxillofacial imaging. Employed in clinical practice for diagnosis and treatment planning of oral and maxillofacial pathologies, maxillofacial surgery, craniofacial growth assessment, and implantology. Going back to its history, it was first developed in 1982 by the Mayo Clinic Biodynamics Research Laboratory for the procedure of angiography. In the 1990s, the CBCT scanners were then dedicated for the oral and maxillofacial region, and it was developed so by Arai et al. In 1996, it was first introduced in the European market as a new TOM 9000. In 2000, the limited CBCT was developed by Morita Co. in Japan. Now, what is the basic principles in image generation? Since the first imaging system was a computed tomography, we will try to explain the CBCT in terms of the CT, or the computed tomography. Now, in case of computed tomography, it consists of array or rows of detectors, whereas in case of a computer tomography, it consists of a single flat panel detector, as can be observed from the schematic diagram below. In a computer tomography, it comprises of a broad fan-shaped X-ray beam, as can be denoted in the schematic diagram here. Whereas in a cone beam computer tomography, and as the name indicates, the X-ray source comes off as a conical beam that goes through the patient and is then collected onto the flat panel detector. In case of a computer tomography, there is a helical progression of the beam acquiring individual image slices as indicated in the image on the right. Whereas in a computed cone beam CT, you have a single or partial rotation of the beam, and a receptor then acquires sequential planar images, as can be denoted by the image on the right. This is the basic geometry of the beam, where you have a cone beam geometry where the beam is conical in shape and it is collected onto a flat panel detector, and it is collected as a single image each time. Whereas in a CT, you have a fan-shaped beam for its geometry, and it is collected as a single slice as it helically progresses over the area to be imaged. So the CBCT image acquisition in a nutshell is X-ray generation, which is then followed by image detection by the detector. There is image reconstruction within the computer system, and finally the image is displayed on the computer monitor. The X-ray tube and the generation systems are for the CBCT are as seen in this image here. From the position 1, you have a conical image which passes through the patient at through the field of view, which is pre-designed or pre-selected by the operator, and the first basis image or the first image is then collected onto the flat panel detector, post which the X-ray source or the tube then shifts a position or angulates itself and then goes to the second position, from where it will perform the same procedure once again. So multiple basis images are collected, and a set of basis images is then known as projection data. The exposure time for an area of view is increased when there is an increase in the number of basis images, and it then proceedingly decreases the voxel size or increases the clarity of the image. The field of view that we talk about is pre-designed within the machine system of the CBCT, and it can be selected by the operator. The field of view is designated as length and width, the smallest of which is 5 into 5 inches, where you can see up to a segment of the jaws. The next is 8 into 6, as denoted by the blue color here. The 12 into 8 inches, where you can see both the jaws, and 15 into 15 inches, where you can see up to the level of the sella turcica. The field of view comprises of a diameter of the cone as well as a height, the height of the image or the area to be imaged. So these are the series of field of views where you can obtain a single segment, a single arch, both the maxillary and the mandibular arch, or it can image up to the sella turcica, or it can image up to the height of the skull. Now, CBCT imaging is dependent on the voxel dimensions, or the unit of data collection is voxel dimensions, which in turn is dependent on the pixel size of the flat panel detector, or the detector that collects the information of the projection data. Now, the voxel dimensions are isotropic in nature, as in the length is equal to breadth, which is then equal to the height. In comparison to the computer tomography or the CT, where it is dependent on the slice thickness or the thickness of the fan beam that then passes through the object or the patient, and also on the size of the detector, the rows of detectors, which then collects the information. It is anisotropic in nature, where the length and width might be the same, but the breadth or the depth, it varies. This image represents the image reconstruction. This is done within the computed system, where the various projection data or the basis images are collected together. There is an offset correction, as in for the different angles from which the X-ray source projects itself, that is corrected within the computational system. A linear gain calibration is done. Defects are interpolated, as well as temporal artifact correction is done to improve the quality of the image. The various projection data are first collected within the detector, and it is transferred to within the computational system. It is known as a sinogram. The sinograms are corrected to form the corrected sinogram, which is then projected as images onto the image display or the monitor. The display can vary in these 4 diagrams. It can be a 3-dimensional reconstruction as denoted in the image A. It can be either the sagittal view, the coronal view, as well as the axial views of the patient are the main image systems that you can see, or the image that can be displayed on the monitor. Going to the artifacts, even the best of imaging systems comes with its own set of artifacts. In case of computed beam tomography, it ranges from beam hardening. This is demonstrated in case of any distortion from metallic structures within the patient, which can be an amalgam restoration or any other metallic FPDs. It can result in the appearance of various streaks and dark bands onto the image display. It can be cone beam related, which is partial volume averaging or undersampling. Because of the conical shape of the beam, it covers only a part of the volume. After which it stops, it shifts its position and then does the X-ray exposure again. Because of this shift in position of the X-ray source, it can cause a certain amount of volume of data to go missing, and this is corrected by the computational system, and it is known as partial volume averaging. Also, it can result in loss of information due to the shifting of position, and this is termed as undersampling. It can be related to the machine itself, or it can be scanner related, where it can be imperfections in the scanner detection, or it can be any impurities on the scanner, or it can be owing to poor calibration, which happens in a machine after multiple series of imaging. It can be patient related as pertaining to the patient positioning, or it can be owing to movement of the patient during the imaging system. This is an image of beam hardening, where you can see streaks and black areas owing to the metallic restoration and the implant, as can be seen in this image. So going on to the limitations and the advantages of CBCT, the limitations, of course, as we talked about before, are its artifacts, the image noise, and the poor soft tissue contrast. Unlike a CT or a computer tomography, a CBCT is only able to show very accurately the bony or the hard tissue structures. It is very limited pertaining to the soft tissue structures. But its advantages are much more, and it weighs heavily in the favor of this imaging system. It is the rapid scan time, unlike a CT, which takes hours on end. The beam limitation, the amount of exposure is very limited in case of a cone beam computer tomography. The accuracy of the image that you obtain for the amount of radiation that you expose the patient to, and also the data set that we receive is a real size data set with a good hard tissue contrast. Also, the machine by itself is compact and cost effective in comparison to the computed tomography. Now, where is it indicated? It is indicated in case of eruption guidance and serial extraction, if you were to decide that, in the field of orthodontics, in craniofacial growth assessment, and in case of orthognathic surgeries. It is very useful for the diagnosis, treatment planning of bony pathologies like tumors and cysts, and also for a very accurate diagnosis of TMJ disorders, in case of upper airway assessments in obstruction sleep apneas, in case of fractures and trauma-related queries, in case of dental caries, root resorption and root fractures, for treatment planning in the Department of Endodontics, and also for cleft lip and cleft palate design of treatment and accuracy of imaging in the field of pedodontics. So I conclude saying that a conventional imaging is basically your IOPAs or orthopantomograms is just a 2D imaging, whereas a CT is sectional imaging with increased exposure as well as an increased scan time. Now therein comes the computed beam, cone beam computed tomography, where you have the best of two worlds, which is sectional imaging, with lesser exposure and lesser scan time. Thank you.